Good afternoon, my colleagues. First of all, I'd like to thank Hikma for inviting me for this symposium. Today, we will introduce a new product for psoriasis treatment, Ilumya, which is tildrakizumab, from the clinical trials to the real-world evidence. So that's my general disclosure, and I believe who start practicing since 1980s, he can witness the journey of revolution of psoriasis treatment all over this decade, we can say, because we have the story started from the monoclonal antibodies in early 2000 with production of the TNF blockers, and then moving forward with IL-12/23, IL-17, ended with an IL-23 blockers. So we have almost talking about 12 approved biologics in psoriasis treatment. And it's very difficult to say now that there is only one key player can help our patients, because the availability of these medications are really good for our patients. We are considered as a privilege that we have multiple treatment options in our hand, which for sure you may be able to find the right treatment for the right patient in the right time. So we have TNF blockers, etanercept, infliximab, adalimumab, certolizumab. We have IL-12/23, ustekinumab. We have another 4 IL-17, secukinumab, ixekizumab, brodalumab, and the IL-17NF, which is bimekizumab. And then we have 3 IL-23, tildrakizumab, gozelkumab, and risankizumab. So today we are introducing tildrakizumab. Maybe the latest one came to the UE market. However, it was the first IL-23 approved, earlier than the available 2 medications, and it's targeting the B19 subunit in the IL-23. And we have 2 phase 3 trials in many number of patients, almost talking about more than 2,500 patients has been exposed to the trial of tildrakizumab in resurface 1 and resurface 2. And they compared 2 different dosing, the 100 versus 200 milligram versus placebo, and in the other trial versus etanercept arm was there. And when we will see the trials endpoints, which is talking about the BASI 90, in the first 12 weeks, we don't see significant difference between the tildrakizumab 100 to 200 milligram. However, there is a huge difference between the placebo and the placebo and shifted arm to the tildrakizumab. It have a significant improvement in terms of almost about 60% of the patient, they achieved the BASI 90 in the week 28. When it comes to the differentiation between etanercept, we have again significant superiority versus both doses of tildrakizumab, either 100 or 200 milligram, versus etanercept, and again versus placebo. And again, when placebo arm has been shifted to tildrakizumab, again we have almost 50% of the patient they achieved BASI 90. So in terms of short-term efficacy, you have a significant superiorities as per both trials in the endpoints. And for sure, we are not treating our patient for 16 or 26 weeks, and always all our medications, we are looking for a long-term efficacy and long-term safety. So that's why we have almost talking about 5 years data with the patient who achieved the BASI either 75 or 90 or 100, and this percentage of patients, we are very well controlled year and year and year, and these are the data of the 5 years trial. We can see almost a flat curve in all, and this is again the most important selling point when it comes to IL-23 blocking and psoriasis treatment, that the patient who achieved this percentage of improvement, he can maintain this result for a long time. And this is the BASI 75, 90, 100 for the first 5 years after the treatment. And this is the absolute BASI, less than 3 or less than 5 or even less than 1. So when we talk about almost 50% of the patient, they have absolute BASI less than 1, means no disease activity, and these results are sustained for almost 5 years. When it comes to the real-world evidence, as all of us know, sometimes even the randomized clinical trials, they have so many restrictions in patient selection and treatment period. However, when we open the place for the real-world evidence, we can see either matched results or even sometimes better results. And so many randomized clinical trials came from different parts of the world, and they supporting the data or even reporting a better numbers in achieving BASI 90. You can see even some numbers is touching 90% of the patient, they achieve the BASI 90. Another real-world evidence came from Spain with all parameters in the baseline, and just 4 weeks, 12 weeks, 24 weeks, we have a significant reduction in either BASI or body surface area or physician global assessment, and all this has been significantly reported with tildrakizumab treatment. And the observation of the investigator here, they are saying that these results are comparable with what we can see from the guselkumab and risankizumab, but significantly they are highlighting that in the other IL-23, it takes longer time to achieve similar results. So here in this real-world evidence, they are appreciating the fast onset of action of tildrakizumab over the other IL-23 blockers, and almost all the numbers are very close to 0 or 1 after this 24 weeks of treatment. Another very important point here that tildrakizumab is the only IL-23 have done a dedicated clinical trials for scalp psoriasis. All the other IL-23, they just have a scalp data, but these are explorated data as a post-hoc analysis from the mother trials. However, here they did a dedicated trial on the scalp psoriasis, and the results here is very, very clear. We have on almost 231 patients has been randomized with the scalp psoriasis, and all the other medications which can be used concomitantly has been prohibited during this trial. And the results here that they are measuring the IgE 0 to 1 at the primary endpoint, and we have almost 50% of these patients in 16 weeks having this IgE 0 to 1 at the scalp, clear or almost clear skin after 16 weeks, and this make the FDA give the label for scalp psoriasis as an adding label for tildrakizumab on top of the chronic plaque psoriasis. And this is something addition which is not there in any other biologic therapy. So having a dedicated clinical trial for scalp psoriasis, that's the only IL-23 have this, and even in the labeling by the FDA, that's the only medication has been added to his label. Another endpoints here, talking about the secondary endpoints, which comes to the 90% response. So with continuation of the treatment, even from the week 12 to week 16, we can see that the patient is still getting a very significant benefit. And for sure, subsequently, the quality of life impact will be positively affected while you are treating the scalp psoriasis. And this, again, has been significantly observed here. The reduction in the quality of life impairment has been reported as early as week 8 versus placebo, and continually to be positively reported up to week 16. These are a few photos from patients who were enrolled in the trials and significantly improved as early as you can see from week 4, and then from week 12 until they reach a complete clear scalp. When it comes to the IgE 0 to 1, the numbers are going higher. From even 16 weeks with continuation of the treatment, 63% of the patient, they achieve this IgE 0 to 1 for the scalp. And when it comes to the scalp PASI 90, again reported significantly in 61% at week 16, and again going higher with the continuation of the treatment. Even here we are highlighting how fast is reporting this result by achieving in each week how we are achieving this high level of skin clearance when it comes to the scalp affection. So it's a dedicated work to one of the difficult to treat areas, and again it's a very adding point and adding value when we have data proving that this medication has been tried in this specific population, a specific location when it comes to the scalp psoriasis. Again, real-world evidence in different body, in different areas in the world, talking about the hard-to-treat areas, the scalp, nail, palmoplantar psoriasis, genital psoriasis, so in different locations, and we have this data saying that talking about the genital physician global assessment, talk about the scalp PASI index, talk about the NAPSI, talk about the palmoplantar PASI, all these we have a supporting data talking about as early as week 4 and as late as week 28. We have a almost complete control in the disease progression, regardless which area we are talking about, either palmoplantar, either scalp, either genital, or even the other areas like the nail psoriasis. So because that's a very important differentiating point when you need to challenge the medication, we're always choosing these locations to know if this medication is really doing well or not. So this supporting real-world evidence from these difficult to treat areas, we have this significant result as early as we mentioned as week 4 and complete control in week 24. What about the safety? I think IL-23 profile is very well known for us. That's one of the most safest biologics compared with others when it comes to comparing versus TNF blockers or versus IL-17. We don't have anything that we need to have locked. The percentage of having either the adverse event of special interest or the adverse event which has led to discontinuation of the medication is really much, much less than compared with others. And we can see zeros in lots of these incidents when it comes to infection, cardiac diseases, endocrine, gastrointestinal. So all the adverse event is reported in the very low level if we need indirectly to compare to other biologics. So I believe with the profile of biologic treatment of psoriasis, it's really very well reported in a very low number. Again, having patients more than 65 years old treated with tildrakizumab is an adding value for us as a very important information to compare the results for the elder population, either more than 65 or less than 65. Again, we have a very comparable efficacy in terms of efficacy and reporting capacity less than 3, as you can see here. And again, it's very important for us to see in terms of safety if there is any specific significant signal for the patient who are more older than 65 or less. Having this pool data is again very valuable information to us to see that we don't have something that specifically need to take care of, especially with this older population. And even some of the network meta-analysis, which is published last year, they are classifying all the medications in terms of favoring the safety profile, and they both tildrakizumab is one of the best medications which having a favorable safety profile versus all the other treatment, even including the conventional systemic therapies or the new biologics as well, as you can see here. What about the comorbidities? When it comes to obesity, which is very well known for us, that when the patient have an obesity, that significantly will impact the efficacy of the medication. And here, a very little different when it comes to the patient who are achieving BASI 90 for the BMI is less than 30 or more than 30. So the differentiation in reporting the BASI 90 was a very minimal, which again making a very important point with the dosage of tildrakizumab every 12 weeks. Even the body mass index is more than 30 or less than 30. We're still having a very good result in achieving BASI 90. Even for the body weight is less than 90 kilogram, more than 90 kilogram, less than 120, more than 120. The absolute BASI less than 3, you'll see the numbers are all comparable. Maybe a little bit difference in the patients who's more than 120, you start to see a little bit gap, which is really difficult for any of the available biologic drugs, because here the 200 milligrams makes a little bit more sense in the patients with more than 120 kilogram. But all the others, if you go for the low dose or a high dose, you have the similar results, which means that the obesity is not significantly affecting the efficacy of the medication, which can be considered a very challenging point while we are comparing biologics versus others. There is no influence in the disease duration. Again, now we are talking about hitting early because the short-term disease duration, you may have a better response. However, here, if you treat less than 5 years, 5 to 10 years, more than 10 years, you can again see a comparable results. The numbers are very close. So again, even you start early or late, for sure, we are assuming that early treatment is always better, but the data that we have here is still giving us a very important information that tildrakizumab can do the needful even if you start late, because the differentiation between less than 5 years, 5 to 10 years, more than 10 years, still there is no significant differences between what the medication can do in these patients in terms of either BASI 3 as an absolute BASI or the DLQI reporting either the 0 to 1 in different trials from different patient profiles. What about the network meta-analysis versus other biologics? As we can see, this new one has been published last year in 2023. While differentiating all these medications indirectly, we can see a very comparable efficacy if you will put the tildrakizumab versus all the other IL-17 or IL-23. All these medications are very comparable in terms of efficacy when we try to compare it in an indirect way here. Dosage, that's again a very important point because you just need to give the medication today, and after 4 weeks, that's the loading dose, and then every 12 weeks as a only single injection, as a only one shot. And this is sometimes can make a difference while we are thinking about how many injections the patient will give per year and how many injections for each dose. When we put all these medications in front of each other, you will see that the tildrakizumab is only 6 injections. However, the others may have even more because the other IL-23, guselkumab is 8 injections per year, and risankizumab, even it's the same dosing regimen. However, in each dose, there's 2 shots of risankizumab versus only 1 INT'L. So in that time, you can compare that we have the least number of injections per year, and this is sometimes can be a differentiating point while you are trying to choose the medication because the patient have injection phobia, patient don't want to come to take a monthly injection. So here we have, comparing with all the other available biologic treatment, we have a very clear differentiation that tildrakizumab have the least number of injections versus all the others when it comes to the interval of dosing every 12 weeks, or even when it comes to the number of shots that the patient will receive during the first year. Access and cost effectiveness is very important because if you compare the annual cost of all the biologics, you may see a significant difference here. And this is a US data. They are concluding that the introduction of tildrakizumab with a 1% annual uptake of 5 years has the potential to reduce the cost of the treatment. Another paper from also US highlighting that it was among the most cost-effective first-line treatment for moderate to severe psoriasis when it comes to, again, cost-effectiveness in the US, comparing all the biologics versus each other. They found that brodalumab, infliximab, apremilast, and tildrakizumab have the lowest cost-effectiveness. So while we have multiple biologics, as we mentioned, we have 12 biologics available all over the world, 11 available in UAE. We have to know which is doing better in terms of which is easier, which is effective, which is safer, which is most also cost benefits. So all these, the highlights that we need to talk about it. And to make it quickly here, we are introducing today Ilumya as a tildrakizumab treatment for moderate to severe psoriasis, achieved consistent clearance across the real-world studies. When we compare the randomized clinical trial with the real-world evidence data, we have some even better numbers. Complete clearance was achieved was almost 80% of the patients after only 3 doses, and 3 doses talking about today, 4 weeks, and then 12 weeks. Ilumya provides a proven efficacy for the treatment of difficult-to-treat areas. As you can see, we have a dedicated trial in the scalp psoriasis, and we have many real-world evidence in the difficult-to-treat areas, palmoplantar, genital, scalp, and nail psoriasis. Ilumya is among the most effective first-line therapies for moderate to severe plaque psoriasis, and we compare the cost-effectiveness versus other biologics. And the lowest number of the annual dose can be the least number of injections. So it's a new approach, it's a new medication. You may find to differentiate between all these medications to find the best treatment option for your patients. So that's why we are here today to introduce tildrakizumab Ilumya for our moderate to severe psoriasis patients. With that, I'd like to thank you very much for your attention. If anybody have any comments or any question, we can discuss it together. Any comment, question? The only head-to-head trial was versus etanercept, but there is no any head-to-head trial has been done, but the network meta-analysis, they are comparing indirectly, and the last one published last year, they are very comparable to each other in terms of efficacy. But head-to-head, no.
What about other difficult-to-treat area? Because here was studied the scalp only.
Yes, the dedicated study. By the way, there is no any IL-23 blockers did any dedicated study for any difficult-to-treat area. So all the nail psoriasis data or genital or scalp or palmoplantar from any of the IL-23 are just sub-hook analysis. But here, the 2 medications, the 2 biologics did dedicated studies, the secukinumab and tildrakizumab. This is the only 2 medications they have dedicated studies. However, for the scalp, Tildra is the only one added in the FDA label that added for the scalp psoriasis.
Did you use it for your patients?
Not yet.
It's available in UAE?
I think it's start to be available in UAE, but it's not, personally, it's not yet available in my funds.
Thank you, Dr.
Thank you.
Any other questions?
Can we use it as first-line therapy?
Sorry?
Can we use it as first-line therapy?
Yes,
Would you
it's among,
recommend as a first-line
all the licensed biologic now can be used as a first-line systemic therapy for the patient who is a candidate for systemic therapy.
No, I mean, like, do you have to start the patient on an interleukin-17 inhibitor, and then if there's no response, then you shift to this, or you can start straight
all
away?
All the IL-23 blockers are licensed to be as a first-line systemic therapy.
Thank you.
Once
Dr.
we
Ahmed,
don't
you have an
have a
experience, a big
head-to-head trial, we cannot say superior. But again, it's good for our patients because we have the new molecules when it comes to IL-17 and IL-23, all are very effective medications. But again, we are still learning and see patients, primary fail to this, secondary fail to this. Why patients are still maintaining a very good result, for example, in any of the TNF blockers. So the key players are too much. So we cannot say superior, but while we are introducing a new molecule.
Where you will keep this medication? For which patient you will give this medication? Because you have now 3 IL-23.
I think so, when it comes to, you will select that this patient can be either for IL-23 blocker, I think any of them can be helpful. Maybe I will not use it in an arthritis patient because it's not yet approved in psoriatic arthritis. So maybe that's one of the points that I will not take this medication. For the patient who really have an injection phobia, that I need to have a least number of injections. As I mentioned, for the difficult areas, something like scalp, I have solid data in my hand. We have another experience with other biologics, is also scalp psoriasis is doing good, but when you have a dedicated label, same like in genital with ixekizumab, so now you have something solid in your hand that this medication have the label in this, but you cannot stratify a specific population that's the patient that only will take benefit from guselkumab or Riza or tildrakizumab because the efficacy are really comparable.
Yeah. Agree.
I think large body mass index, I'm going to go to
yeah. That's again,
as you have been shown now.
We don't have a differences because I can say one of the little bit drawbacks of IL-23 is the obese patients. Obese patients is really challenging for the IL-23, and here we have a very good data that with the obese patient we don't see significant differences even if they increase the dose, except for the more than 120 kilograms.
Thank you, Dr. Ahmed.
Thank you very much.